Good afternoon, this is Dr. Fenton. I'll be presenting the topic you see before you, common elective orthopedic surgeries and their evidence versus non-surgical care. I have no financial interest in any companies, nothing to disclose. So traditionally, people get injured, they see a physician, maybe they get anti-inflammatory medicines, they go to physical therapy. When they're not better, someone injects them with steroids, and then there's no bridge, they just go right to orthopedic surgery. And so that's the traditional paradigm. And a better paradigm really is to have interventional orthopedics before surgery to bridge the gap between simple steroid or catabolic injections and a surgical approach. And so interventional orthopedics is non-surgical, done in the office with image-guided injections. And it's short recovery, rare complications, and it's designed to try to repair or regenerate tissue. And surgery obviously is a hospital or ambulatory surgery center. Scalpels are used, it's more pain, there's significant complications, longer recovery, rehabilitation, and it removes tissue and it actually often causes degeneration. So removing tissue is not the way to go, if possible. So for instance, 95% of meniscal surgeries remove tissue, they don't repair it. And it's been well shown that removing meniscus hastens the onset of arthritis. So then in addition to having a meniscal surgery, you get post-traumatic arthritis, which is pretty inevitable. And then when you look at the surgical evidence, it's actually very poor. So meniscal surgery has undergone several more since this slide, randomized control trials saying it's no better than a sham surgery where they just do surgery with putting the tools in but not taking anything out and don't tell the patient. And they've even shown that for the vast majority of meniscal surgeries, there's no improvement over getting physical therapy. And there's another article, fairly recent, and what you'll see is they talk about non-obstructive meniscal tears. So the classic meniscus that needs surgery when it doesn't get better is a bucket handle tear with people who have no ability to straighten their knee or it buckles routinely. So those are obstructive meniscal tears, and they fairly often do go on to surgery, but all the others really get better if you give them time or conservative treatment. And so the evidence is really there that these should not be operated on. And I'm happy to report more and more surgeons are obeying the evidence. And again, sham surgery was just as good, and most meniscal tears are not you had a perfect meniscus and now you tore it. Most of them are already degenerative, and something that's done at work or some minor injury extends the degenerative tear. So again, most of these, especially in people over 40, are not de novo meniscal tears. They're degenerative that get worse. So another thing that's done commonly is they'll say, well, you have a degenerative knee and we should go in there and clean it up and that'll work. Well, it does not work. And it's been well studied in multiple articles. And so when they show you that nice picture that you had all this crab meat hanging down in your knee, and now we've cleaned it up, that actually causes harm. And so as I wrote at the bottom, some crab meat is better than none. Bad cartilage still has a function. Making it look nice and clean is not good biomechanics. Okay? And then, as I said, that's just the same slide. And what about an ACL reconstruction? Well, some people really need them. People who have repeated pivot, shift, and buckling events that don't get better with physical therapy. But when they looked at two groups treated the same way with really well done, properly administered rehabilitation, the groups were the same. They didn't notice any difference in outcomes. Just one group had a slightly looser knee on physical testing. And I've treated a lot of ACLs without surgery, and I've sent a lot of people for them. It's really an individual decision depending on what people need to do. But it's not, shouldn't be a knee-jerk reaction, if you'll pardon the pun. Not everyone with an ACL tear does better with surgery. And in fact, though not discussed here in slides, when they do the ACL surgery, the cartilage takes a second hit, and they have a much higher rate of post-surgical arthritis than the people who don't have surgery. So it is not without risk. And then, you know, what happens when you get a knee replacement? So finally, they say, there's nothing we can do, you need a knee replacement, which I'll show later is not true. Well, it turns out that 75% don't improve in their pain at 6 weeks and to 6 months, and at a year, 50% don't. And then functionally is what we really care about. Can you do more? Can you do better? Well, 65% don't improve their functional status. Only a third do. So what happens at a year? Well, almost 50% are still on pain medicine at a year for their knee. Their pain score is very high. And a lot of people have ongoing pain, and in one of the golf studies, they did not improve their ability to walk the course post-knee replacement. They had less pain, but they couldn't walk further. So most people only care about function, not just pain relief. We also see a lot more knee replacements in younger and younger patients, and they have a much higher complication rate. The revision rate's higher, and these are not without risk. So what are the risks of total knee and total hip replacement? Well, this is a publication that, and it's been updated, that showed that they keep doing it in younger people. Fewer people get discharged home, which means more people go to inpatient rehabilitation. And although the serious complication of throwing blood clots and causing lung damage or pulmonary embolus went down, the rate of sepsis, which is whole body infection, which almost always requires a prolonged hospital stay, often a port for antibiotics, and pretty frequently ICU, it doubled to 6%. And non-heart attack complications were still 4%. And it's believed that silent heart attacks are up to 12%. And pneumonia is real. So, about 15% of people have serious complications that dramatically drive up costs, but also how well people do after. So then we get to hip surgery. So femoral acetabular impingement is hip impingement. And I see a lot of this, and very few need surgery. So this study showed that there was no difference between surgery and no surgery with physical therapy. So why are they doing it? And arthroscopy has scary risks. So hip arthroscopy, because they pull so hard on the leg to get traction, causes all kinds of other problems. And I'll just let you read the chart. But much to people's surprise, not only did it cause chronic pain in a large percentage of people and sleep issues, but it actually increased mental health problems and systemic problems. So it's not without risk. So what about shoulders? Well, shoulders actually are in the same vein, which is, and there are newer articles on this, which is surgical repair was no better than physical therapy in these rotator cuff tears, which, like meniscus, are often, you have a degenerative tendinosis, degenerative tendons with partial tears, and then you extend them by something that seems injury. But when they looked, there really was very little difference between doing the surgery and having properly done physical therapy. So then some brave surgeons do sham surgery. They put their arthroscopic tools in. They don't tell the patient that it wasn't a real surgery. And they take them out and they see how people do. And they showed there was no difference between sham surgery and labral surgery for these type 2 labral tears or slap tears. And I see a lot of these who do worse than physical therapy with surgery. And there are many treatments for them. Certain slap tears, especially type 3 and 4, they really need surgery or something done. But most of the people I see have these more insignificant tears that are told they need surgery. And so, what happens with this subacromial pain is pain just below the top of the shoulder. And so there are these surgeries where they make room in there. It's called an acromioplasty. And they showed it really doesn't work. And actually there are studies showing that it makes things much worse in the future. So then we get to these big rotator cuff tears, full thickness. And everybody says, oh, a full thickness tear always needs surgery. Well, here's a study that followed them with properly done therapy, and they found that their function was about the same further out without them. There are always exceptions, and I send people to shoulder surgery regularly, but it's not automatic. And what's the failure rate of rotator cuff repair? Well, it's actually really high in rotator cuff complete tears. And so when they're less than 2 centimeters torn, I can repair them without surgery. But in that 2 to 6 centimeter tears, surgery is often indicated when people have dramatically lost function. But once you get past 6 centimeter, you're looking at it being torn again 50% or more of the time in a year. And so are they worth doing when properly done therapy gets these people about as stable? And again, it's individual, but most of the time the answer is no. And so what about these AC dislocations, which is a shoulder separation? Well, they looked at these, and what they found was the surgery group did worse, took longer to get to work, and the only difference in the end was it doesn't look as good, so you have a distorted shoulder, which of course is a problem if you're wearing strapless evening gowns. It could be a problem. But if you're not, then it's just a small cosmetic defect. And again, there are other treatments we'll discuss later to treat it without surgery or the cosmetic defect. And so this acromioplasty I talked about, where they shave it, is no better than sham surgery. And the article clearly stated the findings don't support current practice, meaning everybody's doing these surgeries, but it doesn't work. So what's the lifetime risk of problems with a shoulder replacement? Well, this, if you really look at this, this is actually a scary study, one of the most scaries here, and it's from last year. What they showed was that the rate of people getting pulmonary embolus, which is where you throw a clot to your lungs, which can be fatal, was 61 times over baseline. And they also showed that younger men, their shoulder replacement failed and had to be replaced in the first 5 years, especially if they were age 50 to 55. And other things in the article show how risky this is. And so it actually changed the practice of this in England, because the Public Health Service in England stopped allowing these for all but the most severe cases. And then this is tennis elbow, which very few people will do surgery on anymore, but it showed that it is no better than physical therapy. There are many conservative treatments that work, and it's actually very risky. A lot of people permanently lose elbow function. So there really should be no reason to do this anymore from anybody. So hopefully you're not seeing this. How about spine? Well, not as big a problem in this area, but in many parts of the country, everybody with a disc herniation gets a fusion. And fusions are insanely expensive and really increase complications, and then often increase the need for future surgery. And so they showed in stenosis, which is narrowing of the canal, just doing a simple surgery is just as good as doing a fusion, but again, the fusions cause enormous problems and risks, okay? How about epidural steroids for people with sciatica? Well, the only reason to do them is for acute sciatica. Once people are chronic, they do not work, and they should have no role. But I saw someone today who had 9 steroid injections for chronic sciatica. They didn't work, but it sure reduced their bone mass nicely, okay? And so why are all these surgeries failing to show improvement? All these high-level studies that have been done in the last, mostly in the last 8 years, show these shouldn't be done, that the overwhelming majority of elective orthopedic surgery barely has level 3 evidence. And a lot of it has no evidence when you look. Well, they're being done because everybody's using what's called the structural model of pain. That says, I see it on MRI, that must be the problem. Well, that's not true a lot. So you say, what do you mean? I see a meniscal tear. Well, they're very common in older people, and that means over 50, asymptomatic. Big studies on knee arthritis done, one of them is the Framingham Heart Group, and what they showed, and try to hear this very clearly, there was no correlation between loss of cartilage in the knee down to bone on bone and pain or functional loss. And that's true in every joint of the body. There is no relationship to degenerative osteoarthritis in any joint of the body and pain and function. People are a lot more functional than that, and your body has many adaptations. So bone on bone really doesn't matter. It really matters what your function is and pain. They're not related. So here's a chart of all the normal things in asymptomatic people that you see that are horrible on MRI, but yet these are asymptomatic. So percent age 20 to 70 with bulging discs, 87%. This degeneration, over a third at age 20 and almost 100% at age 80. These are normals with no symptoms. How about in the shoulder? Partial rotator cuff tears, 22%. Other abnormalities, 96%. Now I use ultrasound, and I'll tell you that in ultrasound, when I see a normal shoulder in someone who's over 50, it's so rare. I see all kinds of pathology. Doesn't mean it's causing the problem. It's an image, not their function. Knees, where we see the most. Well, less than 40 years old, 19 to 43% have osteoarthritic degenerative changes. So 19% at 40 years old and 43 at 40%, right? And so cartilage defects an enormous number, meniscal tears a lot, and then in hips, these cam and pincer deformities, which are impingement syndromes, you see it in 1/3 to 2/3 of normal people, and labral tears, 2/3 of people. Right? And lastly, in the foot, the ankle ligament pathology, the ATFL is the sprained ankle ligament, 1/3 of normals have it. So just because it's on imaging doesn't mean it needs to be treated, but more importantly, doesn't mean it's the problem. You need a good history and a really good physical exam, and their symptoms have to match your history, your physical, and the MRI to be reasonably sure it's the problem. And what I see now is people diagnose the MRI, and they don't do a history, and they don't even do a physical. So you have to unfortunately read the chart to see if due diligence is being done. So what's conservative treatment after injury? Well, first, oral and injectable corticosteroids really should not be used, and they're used all the time. They cause degeneration. They're catabolic. They break down normal tissue. Anti-inflammatories, which we'll also talk about in a moment, interfere with normal healing in the acute period. They should not be used. Everybody uses them, but they interfere with normal healing. So what's the real key? Well, the real key, if you have especially a patient who's not going to do his or her work, is really properly done physical therapy. And proper physical therapy is the physical therapist in the room watching and using their hands to make sure the patient's doing things correctly. It's not just stretching and strengthening. It's really observation for properly done, what's called dynamic muscle stabilization and postural exercises, strengthening without substituting the wrong muscles, and really relearning how to use your body properly. And modalities, which a lot of therapists use, heat and ice and ultrasound and iontophoresis and electrical stim, none of those really have been shown to work very well. They make people feel a little better temporarily, but they're not the core of rehab. So other than early pain relief, they really shouldn't be part of the treatment. So again, the therapist has to be physically there monitoring. They can't say, do 3 sets of this and you'll get better. Someone has to watch for substitution and patterns. And so being in touch with the PTs, reading the notes, and asking the patients if they're getting that one-on-one care is what's necessary. So physical therapies didn't work. Maybe they had a steroid injection, it didn't work. So what's the better approach before surgery? Well, let's not cut stuff out. The real goal, and there are more and more people doing this, is precise image-guided injections to try to stimulate a healing response. And they're out there, and there's lots of data on it. So that's interventional orthopedics. Who does it? Well, a small percentage of physical medicine and rehabilitation doctors do it. A very tiny percentage of interventional pain management anesthesiologists do it. And more physicians who are primary care sports medicine fellowship trained do it. And really less than 1 in 1,000 orthopedic surgeons do it. It's very rare, but it's growing. So it's using things that you can inject that facilitate healing of musculoskeletal structures, putting those materials exactly in the right place using image guidance, not the poke and pray method or blind injections, and figuring out how to do it better. We're trying to repair things, not take them out. And so it's going to replace most elective orthopedic surgeries because it's less invasive, the recovery is enormously quicker, and the side effects and risks are really tiny, and it doesn't take things out, it doesn't damage the mechanics of the system, okay? So it's ultrasound guided. For tendons and ligaments, it's something called percutaneous needle tenotomy. That's poking holes in the tendon in the same plane as the fibers and flushing out the bad material in tendons and ligaments, okay? And it can be done with very dilute local anesthetic. It should not be done with steroids. That breaks things down. It can be done with dextrose, 10 or 15%, which is called prolotherapy, and it is been around for a long time, and it's mandatory covered in Vermont's workers' comp rules. Or orthobiologicals. Orthobiologicals are using superconcentrated platelets or platelet-rich plasma, rarely amniotic membrane injections, and bone marrow concentrate. So that's for tendons. For joints, it really is just the orthobiological injections of platelets or bone marrow. For joints, the meniscus and the knee, the labrum, tears in shoulders and hips, and the spine, joints, ligaments, discs, and muscles. And again, the substance used are mostly PRP, which we'll talk about, and sometimes bone marrow concentrate. Lastly, in interventional treatments are treating nerves, which is something that should be done more, because peripheral nerve entrapments like carpal tunnel and cubital tunnel are actually very easy to treat using image-guided, what's called hydrodissection, or separating the nerve from its tunnel. Really all you use is buffered 5% dextrose, which is IV fluid. But in some nerves, you need to use platelet lysate, which is an extract of PRP. So the problem is that to do this, you shouldn't be doing blind injections. So 70% of doctors at least, and probably 99% of orthopedic surgeons, just palpate, put the needle in, and hope they're in. Low accuracy guided, or maybe using x-rays or ultrasounds, but not putting them in all the structures that needed, and doing precise guided injections is growing, but it's very rare, okay? And so here's just a report that image guidance improves accuracy. So I'll give you the shoulder example. In the shoulder, they did a really great study on orthopedic surgeons, and they found that the miss rate of orthopedic surgeons using blind technique who all had shoulder fellowships was 46 to 80%. With ultrasound, the miss rate is in the 3% range. In the knee, unless you go one particular way, the miss rate's about 50%. That one particular way from the outside, you damage the joint cartilage. So doing it under ultrasound, you don't miss and you don't damage the cartilage. It should be the standard of care. It's been the standard of care in Europe for over 25 years. I'm slightly embarrassed it's not. But that's what happens. And so you really want image guidance. In the hip, no one does it without image guidance. They usually use x-rays, which is perfectly adequate. But you missed the hip. But it's true in the other joints too. So interventional orthopedics is, again, not a blind injection done by the surgeon, not just dumping stuff in the joint, even under imaging, because all the structures that are involved need to be treated. It's not a joint problem. It's a dynamic system with ligaments and tendons and meniscus and joints, and anything that's not right has to be treated. So what else? Well, some doctor took a weekend workshop and he's going to dump some low concentrated platelets or bone marrow into your knee. Well, it's not going to work if you don't have enough platelets or enough cells in the bone marrow. If you just put this thing in at the end of your procedure, it probably is going to work, especially since mixing it with full-strength local anesthetic destroys the product. And I'll mention that Marcaine or bupivacaine is toxic to joints, and everybody uses it in this town, okay? Or a practitioner of any kind offering to inject amniotic or umbilical cord stem cells. Well, first of all, there are no stem cells in those products. The FDA lists it as dead tissue, and the FDA and the FTC, Federal Trade Commission, say if you advertise amniotic or umbilical cord products as stem cells, you're committing criminal fraud, or certainly civil fraud. So luckily, the clinic that we had in Williston, the two of them have folded, but be on the lookout, they'll pop up again. And the only role of amniotic products is as a membrane graft. It is not a cell product. So how do you heal? Well, without inflammation, you can't heal. So you cut your finger, platelets come to the area, they form a clot, they scaffold the clot, and they release growth factors. Then you get inflammation. Without inflammation, you don't get proper healing. The inflammation attracts all the cells to the area. And then those cells proliferate whatever it is, ligament, tendon, cartilage, muscle, skin. And then after it grows, puts all the collagen there, the collagen has to go from random to lined up. And once it's lined up, that's called remodeling. And then it has to mature and tighten, and then you get healing. If you don't have a normal inflammatory state, you won't heal. So if you blunt that, you don't get as good healing. So anti-inflammatories blunt that normal state. And they really should not be used in acute injuries, even though all the ERs give it out. But the ERs give it out so they don't have to give out narcotics because they're worried about people using narcotics. But they should not be used in acute injury. you will not find one study that says they're advantageous in healing. They never are. So what if you're taking it when you get injured? Well, you'll bleed a lot more. So people who pop them when they're working or pop them when they're skiing and get hurt, they bleed more. They block inflammation, they block healing, they block the production of normal chemicals of healing, and they lead to decreased strength of the final tissues. They also, by the way, with one exception, block the production of the normal healthy chemicals in your joints. They're called GAGs, glucosamine, chondroitin, hyaluronic acid. So if you block them, you get increasing degeneration. So all these products actually measurably increase the rate of arthritis. Great stuff to take, huh? So everybody takes them there for headaches and menstrual cramps. They really shouldn't be for acute injuries. What about steroid injections, oral or injectable? Well, they really interfere with normal healing in a much more dramatic way. They're toxic to your stem cells. You need your stem cells that are circulating in your body and in your joints to help heal. They increase the risk of sepsis, which is whole body infection, about 3%, which is a big number. And they can cause death of bones or osteonecrosis, which you see in people who've been given high dose steroids for a week or two sometimes, or people who've had cancer and then all of a sudden they have osteonecrosis or avascular necrosis of their joints. If you put them in and around a tendon, they soften and destroy the tendon and can make it rupture. If you put it in cartilage, they break down cartilage. The other thing they do is they inhibit your adrenals for up to 2 months, and that's measurable on labs. So that's your stress management. I'll might add, they're also immunosuppressive, and last time I checked, we're in a pandemic. Immunosuppressing people is not recommended, and 3 of my professional organizations recommend not using milligram steroids at this point because of the pandemic and immunosuppression. And then when you give steroids to a peri or postmenopausal women, they permanently lose bone mass. Great idea. Again, they kill cartilage cells in arthritic joints, so they cause progression. So an article showing the 3% rate of sepsis is still present. And then another article showing that it increases the risk of ending up with a knee replacement. And then if you've had steroids within 3 months of getting your knee replacement, the chances of getting an infection are enormously higher. So this picture is about someone who I used to see a lot of these in the 90s and early 2000s. People would get 3 steroid epidurals for back pain. Why 3? I don't know. There's no science behind it. And then a tiny percentage of people, but it's noticeable, would get permanent alteration of their set point for their adrenals. They get what this woman has, which is a permanent 50, 60 pound weight loss that they never lose. And you know, you can't fix that. And so I used to see them pretty regularly, but now I don't see them as much, mostly because people don't do as much multiple steroid injections. But I saw someone today who had 7 steroid injections in 7 months. It's amazing she has any bones left. So causes bone loss in perimenopausal and postmenopausal women, and the things we did, and plus it increases infection risk. So what can you use? Well, and this is happening more and more, and I'll show you the research. You can use injectable orthobiologicals. So PRP is just your own platelets concentrated, and they have to be concentrated a lot. Bone marrow concentrate from your own bone marrow. Fat grafts for your own graft, which is only about 1 ounce. And sometimes amniotic membrane as a collagen graft, and it's particularly effective in muscle tears. So I saw a baseball player recently with about a 5-inch defect in his hamstring. The best treatment for that is an amniotic membrane graft injected in, and it will regenerate his muscle, okay? And that's what it's used for. So platelets are in blood. They're actually physically attracted to the shredded ends of collagen or to damaged tissue. They grab onto it, they form a scaffold, they pull their ends in, and then they release their growth factors, which will trigger your cells in the area to repair it. I'm losing my button here. And they have enormous amounts of growth factors, and they increase the speed of repair of all collagen-containing products. They can't regenerate joint cartilage or hyaline cartilage, but they can tendons, ligaments, fascia, and they can dramatically improve the biochemistry of joints. They also can treat muscle injuries that aren't as extensive as the one I mentioned. And platelet procedures are, you take blood out, it's spun down in either a commercial system or in a lab like I have. You have to concentrate them pretty high. If they're not concentrated to 5 times what's in blood, they don't really work. So a lot of people use very weak systems. They work better and they hurt a lot less if all the red cells are taken out, and it releases growth factors. Platelet lysate is where the platelets are broken open and filtered, and they can heal the sheaths around nerves, or myelin sheaths. So they're used for epidurals, transforaminal epidurals, and I use them mostly for more severe carpal tunnel syndrome, tarsal tunnel, ulnar nerve entrapment. They work very well, and usually for those it's one treatment, which is nice because it's one treatment. So this is an old slide of regular PRP, which is full of red cells, and concentrated PRP. At this point in the process, what I make is pure yellow. There's no pink in it at all. So this is an old slide. I just didn't make a new one. And then when people say there are no studies, well, this is a clickable, if you go to the website, list of every randomized control trial on PRP as of, I think, late 2018 or early 2019. And so a lot of these are level 1 randomized control trials. And so at this point, in terms of the level of research, in knees and tendons, it's level 1 evidence. And I might add that it used to be paid for by many insurance companies, and now it is officially paid for by Federal Blue Cross and Military Health for knees and tennis elbow. But you can see all the studies, and it's really effective in most joints and tendons, pretty much universally, depending on how bad it is, and we'll get to who's a candidate in a bit. So what about a platelet lysate injection instead of a steroid epidural? Well, this is one study that was published that showed that not only was the functional rating enormously better, but the duration lasted enormously longer. So these should replace steroid epidurals because they stimulate healing, and they don't do all the bad things. They don't produce bone marrow. They don't cause osteoporosis. They don't suppress your adrenals. They don't cause scarring. They don't lead to softening of connective tissue. They're actually healing products. Very simple to do. You just have to have someone who has a lab to make lysate. So when you're looking at the spine, who's a candidate for platelets or platelet lysate? Well, acute cervical and lumbar radiculopathy, which in the lumbar spine is acute sciatica with a disc herniation often. If you can calm it down, they can go through rehab. Very few people need surgery for their discs, very few. More chronic problems that are more related to the joints, lumbar pain, neck pain, with or without nerve pain. And I actually treat a fair amount of spinal stenosis, but that's a very complex treatment. Joint pain from whiplashes like in the neck, sacroiliac pain and rib pain. And then with extremities, PRP is really for mild arthritis, especially if there's a little instability where the ligaments are a little loose, so you treat them. Tendonitis and small non-retracted tears, and rotator cuff with partial tears, especially what I see is people treat the tendons, but they don't treat the ligaments that are loose. Works very well. I almost never have sent anybody for surgery for partial tears. And ligament tears without retractions, like ankle ligaments, medial collateral ligaments, the ulnar collateral ligament in the elbow, which is pitcher's elbow or a Tommy John elbow. And for extremity platelet lysate, again, it has to be done under ultrasound guidance. I did a carpal tunnel today, and her nerve was 15 millimeters squared in diameter, normal is 8. So I surrounded the nerve with platelet lysate and then separated it from the ligament on the palm, also with platelet lysate, and that'll be one treatment. So carpal tunnel, cubital tunnel, other entrapments. And the lower extremity, it's tarsal tunnel. Baxter's nerve is what people get when they're told it's plantar fasciitis, but it's really a nerve, and other nerve entrapments. This one's good. I treated the lateral femoral cutaneous nerve. That's gun belt neuropathy, and I probably treated 7 state troopers when they switched from Ford Crown Vics to Chevy Luminas. The seats pressed on their gun belt so much that it compressed that nerve. So I probably saw 7 of them and was helpful in getting them to go to Dodge Chargers and off of Luminas for that reason. And then when people say there are no research on bone marrow as a source of stem cells, well, here's a chart showing every randomized study done, and it was 10,000 patients. And if you look at the literature from a French physician, he has 30 years of collected data showing how effective it is. So there is research. It's not at the level 1 evidence level of platelets, but there's a lot of it and it's ongoing. So it's not without research. And then bone marrow concentrate is really for select people. It's for moderate to advanced osteoarthritis of any joint. It's most effective in the knee, ankle, shoulder, elbow, and wrist. And in the hip, it's very select people are going to be effective. The hip's the least likely to get better without very careful patient selection. It's for large tendon tears, especially rotator cuffs, where there's retraction, but there's less than 2 centimeters. And bone marrow concentrate is so thick, it'll fill it in. And I've treated a lot of Achilles tendon ruptures with this quite successfully without surgery, including, again, several police officers. And ligament tears, I treat ACL tears when they're not retracted or when they're what's called blown in place, where it's not functional, but it's not torn and separated. And then how about safety? Well, the downtime's very low. Some people have to take maybe 1 or 2 doses of pain medicine. The infection rate is actually 0, which is pretty amazing. And most people just have pain and swelling for a few days, and they can go back to activities pretty quickly. It depends on the procedure done. And so the goal of this study was to say, don't trust a diagnosis that's based on imaging only, except for, of course, fracture. Fracture's real. When you see fractures, you have to get it treated. Imaging is not the way to diagnose things. It's a history, a properly done physical, and does the imaging support it? And unfortunately, a lot of care now is way too quick to take the time to make a good diagnosis. The most important thing is to have a good relationship or good contacts with skilled, conscientious physical therapists who know what they're doing. To try to avoid steroid injections, they're only to create a window of time of pain relief so you can rehabilitate. They don't fix anything. So they have a role, but it should be minimal and rare at this point. And try to think before surgery of someone who does interventional orthopedics. There are a couple of people at the University of Medical Center who do it now, Sharon Health Center, Alice Peck Bay, someone in Plattsburgh. There are people who do this there, and it's growing. Unfortunately, there aren't that many. And then, you know, when surgery is proposed, is this one that has evidence? Is this really necessary? Do they have severe mechanical symptoms for their meniscus? Is this knee replacement really necessary? Is it going to improve their function, or are you just doing it because the x-ray looks bad? And so that's the conclusions, and I hope this has been helpful. I'm certainly available for questions, and hopefully the staff can provide you my email if you have any needs to contact me. Thank you very much.